Good day, learners. I am Mrs. Farinoemi by name, and I am one of the tutors that will be taking you pharmacodynamics and chemotherapy in the second semester. I am also the facilitator for this course. So I want to welcome you to this second semester pharmacology class. Then I want you to take notes that this lecture or this course is very, very important for you as a nurse. So that is why it is important for you not to skip any part of this video. Please make sure you watch this video from the beginning to the end because it's going to benefit you. You know that as nurses, we are professionals and we have scientific rationale behind everything that we do. There is nothing we do in nursing. There is no care, no drugs we administer to our patient that does not have a scientific rationale to back it up. And that is what makes us to be what? To be different from the quacks. You know that when quacks take care of the patients, when they attend to patients, they don't know the scientific rationale. They don't know the reason why they are doing most of those things. But as nurses, we should know the scientific rationale behind everything that we are doing. So most of the medications that we serve our patients, we need to know the mode of action. Very, very important. We need to know the drugs that can actually that can affect their absorption. What are the drugs that can interact with them? What are their side effects? What are the adverse effects? What are the contraindications? What are your nursing responsibilities when it comes to taking this medication? What are your nursing responsibilities when you serve patient medication? You should be able to explain the mode of action. When your patient asks you that, oh, nurse, you are giving me this particular medication. What is it used for? How does it work? What should I expect? You should be able to what? To educate your patient on the mode of action, the side effects, what are the do's and don'ts of that particular medication. So that is why it is important for you not to miss this lecture. It is very, very important because it will enhance your knowledge of pharmacology. It will make you, to make you to be a better nurse and to be more what? Professional. And that will what? That will make you stand out and be different. That is the difference between you and a quack. So I want you to take every part of this lecture, every part of this video, I want you to take it serious. So today we will be talking about what? Cardiac medication. Cardiac medication is very broad, but we'll talk about both the ones that are common and the ones that are not common. So we are starting with peripherally acting alpha-adrenergic antagonists, which is also known as what? Alpha blockers. So what this medication, what does it do? How does it act? The examples of this medication, we have doxazosin, we have prazosin, we have terazosin. So this medication decreases sympathetic vasoconstriction by reducing the effects of norepinephrine at the peripheral nerve endings, resulting in vasodilation and decreased BP. If you are not grounded in the knowledge of the nervous system, you might have a little bit of difficulty in understanding this. So this sympathetic nervous system, know that it is the sympathetic nervous system that plays a role in what? In fight and flight response. And it is the sympathetic nervous system, one of the major work of sympathetic nervous system is that it helps in what? Vasoconstriction. It helps in bronchial dilation. So it is responsible for the fight and flight response when you're in trouble, when you're in danger. It is this sympathetic nervous system that will switch into action, that will dilate your bronchioles, so that you can what? So that you can breathe, you can take in enough air. It will make your what? Your pupils to be more dilated so that you can see. It will bring about vasoconstriction so that your BP can what? Can goes up. So this norepinephrine works together with the sympathetic nervous system. It's just like a neurotransmitter. And we all know that it is produced from the adrenal medulla. It works together with the sympathetic nervous system to what? To produce the effect of what? Fight and flight response. So what norepinephrine does is that it causes what? Vasoconstriction. It makes the blood vessels to constrict so that the blood pressure can go up. So what this drug will now do is that it will decrease the effect of the sympathetic nervous system. And it will reduce the effect of norepinephrine because their own work is to cause what? Vasoconstriction. So when you now give your patient alpha blockers, it will reduce the effect of norepinephrine on the peripheral nerve endings and bring about what? Vasodilation. Immediately norepinephrine is reduced, the effect is reduced. So definitely you are going to have vasodilation. And immediately there is vasodilation, what will happen? The blood pressure will go down. You know that our blood vessels, they are just like a pipe. They are like a pipe or like hose that we use in fetching water in our various homes. You know that when there is reduction, or when there's something like a pressure or something obstructing this blood vessel, what will happen? Or there's not something constricting it, what will happen? The rate at which water is pumping in this hose, the rate will what? The force will increase. So this is exactly what happens in our what? In our blood vessels. So immediately they are constricted, the force at which the blood is pumping will increase. But immediately they are relaxed, then the force at which the blood is pumping will what? Or the blood pass through them will be reduced. So this is exactly the mode of action of this particular medication. We have different side effects, but the most important one here is orthostatic hypotension. It brings about orthostatic hypotension. What do we mean by orthostatic hypotension? When the patient has been lying down or has been sitting down for a long period of time, and the patient just suddenly stands up, then it can bring about what? Orthostatic hypotension. So this is where your nursing responsibility comes in, where your patient has been sleeping or has been lying down. They don't just stand up all of a sudden. You educate them not to stand up all of a sudden. If your patient is lying down, you tell them to gradually change position from lying to sitting before they now what? Before they now stand up. Then it can also cause reflex tachycardia, sodium and water retention, edema, weight gain, gastrointestinal disturbances, drowsiness, nasal congestion, and sexual dysfunction. What are the contraindications? Who are the patients that you can administer these drugs to? Patients that are hypersensitive, that are hypersensitive to the drug. Patients with liver disease, because it is what? It can affect the liver. Patient with blood dyscrasias. This is a blood disorder that affects all the white blood cells, the red blood cells, and the platelets. Then pheochromocytoma. So it is a hormone-producing tumor of the adrenal gland. So this pheochromocytoma, what happens in this condition is that the blood pressure goes up abnormally, the heart rate, the BP, the respiratory, everything goes up abnormally. So this particular medication is contraindicated in a patient with what? Pheochromocytoma. Then nursing responsibilities. Watch for orthostatic hypotension, which is intensified with prolonged standing, hot baths, showers, hot weather, alcohol use, and strenuous what? Exercise. Patients should consume no more than what? 2 cups of carbonated coffee, tea, or cola per day. Patients should take medicine at bedtime to avoid drowsiness during the day. You know, I told you one of the side effects of drowsiness. So it is not a medication that you administer to your patient, and the patient will start driving around, or the patient wants to go to work. No. So this medication should be taken at what? Bedtime, because automatically you know that the patient is going to sleep. So you educate your patient that make sure you take this particular drug at bedtime to avoid what? Drowsiness. So it is not a medication that a patient will take and then go to work. Then discontinue slowly to avoid what? Rebound hypertension. So you don't want to stop this drug abruptly. So you don't just discontinue this medication abruptly, you wean them off gradually. It's like you taper it off. Just like corticosteroid, where you put your patient on prednisolone. You don't just wean them off the prednisolone. You taper it, you reduce the dosage gradually until the patient stops what? Using it. So do not what? Stop it abruptly. So if the patient about forced dose effects of severe orthostatic hypotension, and to avoid hazardous activities and driving for 12 to 24 hours after the initial dose. To decrease the risk, instruct patient to take first dose at what? At bedtime. Very important. Now let's go to angiotensin converting enzyme inhibitors, the PRIL. You know that most of the medications that falls into this category ends in what? They ends in PRIL, lisinopril, captopril, PRIL. So this is also one of the things that will help you to remember. So most of these medications are ends in PRIL. Once we hear the PRIL at the end, like they are like a suffix. So this PRIL is like suffix, the words that ends those medications. So they are like a what? They are like suffix at the back. So this medication ends in what? PRIL, lisinopril, captopril. So you will know that this will give you a clue that they are angiotensin converting enzyme inhibitors. They are angiotensin converting enzyme inhibitors. So from the word inhibitors, that means they are inhibiting something. They are antagonizing something. They are stopping something. So these angiotensin converting enzyme inhibitors prevents peripheral vasoconstriction by blocking conversion of angiotensin 1 to angiotensin 2. And for you to be able to understand the mode of action of these angiotensin converting enzyme inhibitors, you have to have a deep-seated knowledge of the RAS system. RAS system, that is renin angiotensin aldosterone system. If you don't have the knowledge, you cannot understand the mode of action. So I want you to read about the RAS system. So that will take me to the next slide. So read about the renin angiotensin aldosterone system and write your answer in the comment section. Please don't copy and paste from the Google. Go and read it, digest it, understand it, and then write it in your own word. What you actually understand about renin angiotensin aldosterone system, indicate in the comment section, because it's actually going to help you. It will give you a better understanding of how angiotensin converting enzyme inhibitors, how they work. You know that if angiotensin 1 is not converted to angiotensin 2, then the blood pressure cannot go up. It cannot go up. So this angiotensin 2, what it does is that it makes the blood pressure to what? To go up. It increases blood pressure. It's a vasoconstrictor. It also influences the renal tubules to what? To retain sodium and water. It helps in the production of what? It stimulates the release of what? Aldosterone. So these are the things that angiotensin 2, these are the things that it does. So it's just that it plays a role in increase of what? In increase of blood pressure. It is the one that makes, it is this angiotensin 2 that helps the blood pressure to what? To goes up. So angiotensin converting enzyme inhibitor prevents angiotensin 1. It prevents it from being converted to what? Angiotensin 2. And once angiotensin 1 is not converted to what? Angiotensin 2, what will happen? Definitely we have vasodilation, because the work of angiotensin 2 is to cause vasoconstriction. So angiotensin 2 will not, the angiotensin 1 will not be converted to what? Angiotensin 2 when you give your patient ACE inhibitors, because it will prevent it from being converted. So that's why we call it angiotensin converting enzymes inhibitor. Now, what are the indications? 1, hypertension, of course, heart failure, myocardial infarction, diabetic and non-diabetic nephropathy. Then it is used for what? Stroke prevention. What are the side effects? It can also cause postural hypotension, headache, dizziness, nagging, dry, irritating, non-productive cough. It can cause rash, angioedema, hyperkalemia, neutropenia, mainly with captopril. So please take note. Neutropenia occurs mainly with what? Captopril. So you know that neutropenia, neutrophil is one of the what? Major components of our white blood cells. So there will be a mass reduction in the amount of what? In the amount of neutrophils, especially with what? Captopril. And you know that it is the white blood cell that plays a role in what? In fighting of infection. So these neutrophils will be what? It will reduce in number, especially with what? Captopril. So this is one of the major side effects. There will be bruising, petechiae, there will be bleeding, diminished taste, then fetal injury in the 2nd and 3rd trimester. Now, I want you to take note of this major side effect, the most common side effect that you need to know. So even if you are not going to know all the side effects of ACE, please know these 4 most common side effects. Very, very important. So that is why I use the acronym. You know that it is known as what? Angiotensin converting enzyme inhibitors. So I use the acronym to actually what? To form the what? The side effect, so that you can remember. So if they ask you that what is the most common side effects of angiotensin converting enzyme inhibitor, this acronym will help you to know it. So the first one is angioedema. First one is angioedema. The second one is cough. Then third one, which is E, electrolyte imbalance. Then we have I, which is fetal injury. So you have to know these 4 most common side effects of angiotensin converting enzyme inhibitor. Now, this angioedema, what is angioedema? So angioedema, when you have seen a patient with angioedema, you know, everywhere will be swollen up. There will be excessive swelling of the lips, of the throat, you know, all the features, the tongue, everything will be swollen. In fact, and it can lead to what? Respiratory distress. It can lead to total blockage of the airway if you are not careful. This particular angioedema. Then another thing is what? Cough. Why? Why does this cough occur? Especially with angiotensin converting enzyme inhibitors. There's something we call what? bradykinase in the lungs. So it is believed that this ACE, what it does is that it is believed that it prevents the enzyme, or it inhibits the enzymes that breaks down the bradykinase in the lungs. And these bradykinase are what? They are inflammatory mediators. That is their own role. The tachykinase, the bradykinase, they are what? They are known as inflammatory mediators. So when you place a patient on angiotensin converting enzyme inhibitors, it inhibits the enzymes that breaks down the what? The bradykinase. Because once this bradykinase, because they are inflammatory mediators, what they do is that they want to fight infection. So it makes you to react to some things. Maybe when you take in maybe strange infectious things, or you inhale something that can actually affect your respiratory system, it is the bradykinase that will fight it, so that you can actually cough it out. So it brings about like a cough, what? A cough reflex. So these angiotensin converting enzyme inhibitors now prevent what? It inhibits the enzymes that breaks down that bradykinase. So you now have enormous amount of them when you are taking angiotensin converting enzyme inhibitors. So by the time you have excess of this bradykinase in the lungs, what will happen? You begin to cough in excess. You begin to have what? Excessive cough. It will stimulate or produce excessive what? Cough reflex. So this is just the pathophysiology behind that cough. Then there will be what? Electrolyte imbalance. There will be excess of hyperkalemia. There will be too much of potassium in the blood. The normal potassium level is 3.5 to 5.0. Now, angiotensin converting enzyme inhibitors makes the potassium level to what? To increase excessively. So when a patient is on this drug, you have to monitor their potassium level, because potassium, too much of potassium is not good in the body. By the time it's increased more than it goes beyond 5.0, it can lead to what? Abnormal cardiac rhythm. It can cause cardiac arrhythmias. So you have to continue to monitor the potassium level of these particular patients when they are on angiotensin converting enzyme inhibitor. Then it's contraindicated in pregnancy, because it can cause what? It can cause fetal injury. So you don't want to administer it to what? To pregnant women, especially in second and third trimester. Now, what are the contraindications? History of angioedema. If somebody has been developing or has been having this particular angioedema, maybe as a result of any other condition, you don't want to administer it to them. You don't want to give it to pregnant women. You don't want to give it to a patient with what? Kidney problem generally, or bilateral renal artery stenosis. And why do you not want to give it to a patient with kidney problem? Because of what? Hyperkalemia. If you give it to a patient with bilateral renal artery stenosis, or patient with any form of kidney problem, how do you expect them to get rid of that excess potassium? So that is why it's contraindicated. Now let's go to nursing responsibilities. Closely monitor blood pressure, especially for 2 hours after the first dose, because severe first dose hypotension often develops. Teach patients to rise slowly, to change the position. I think I said it earlier on too, when we were talking about the alpha blockers. You tell them not to stand up suddenly. They should rise slowly from a lying to a sitting position to reduce postural hypotensive effects. Then before administering this medication, assess patient for history or presence of renal impairment. You don't want to administer this medication to patients with kidney problem, because they can't get rid of the potassium. Because one of the major side effects of this drug is what? Hyperkalemia. So please take note, it affects potassium level among all the what? Electrolytes. It doesn't affect the sodium level, the magnesium level. It affects majorly the potassium level. So administer on an empty stomach for best absorption. Then patient should notify healthcare provider if cough what? If cough develops. I remember some years back, when I just left the school of nursing, I remember my mom was very hypertensive, and she was placed on this particular angiotensin converting enzyme inhibitors. So, being a young nurse, I wasn't grounded. My knowledge of pharmacology was not that deep back then. So she started coughing. She started reacting to this particular medication. And I was like, what is going on? I didn't even know she was reacting, because I didn't know it was a side effect to that particular. I think she was placed on lisinopril. And she kept on coughing, and we were administering different cough medication, cough suppressants and all those stuff. So it dawned on me on a particular day that, okay, let's go back to the clinic and see the doctor that actually placed you on this medication. So we decided to go back to the clinic, and it was when we got there that we discovered that the doctor told us that, oh, it is one of the major side effects of lisinopril. And she was changed to another drug known as what? ARB. We'll still get there. We'll still talk about this particular ARB, the valsartan, the candesartan, and all those stuff. So this particular side effect, which is cough, it can really be brutal when you put the patient on angiotensin-converting enzymes inhibitor. So it can really be very what? It can be disturbing. It can really make patients to go on sleepless nights if you don't do something about it. So you have to monitor your patient for this particular side effect. Now, teach the patient to avoid potassium supplements or potassium-containing salt substitutes. And why do you want to do this? One of the major side effects is what? Hyperkalemia. This patient will have the level of potassium will go above normal. So this is not the time to put your patient on what? On potassium supplements. In fact, you have to make sure that you give them food that are not high in potassium. This is not the time to give your patient banana. You know, banana is very rich in potassium. Which other food is rich in potassium? We have sweet potatoes, yes. They are very rich in potassium. So this is not the time to give your patient food that are rich in potassium because it will make the matter worse. Then you have to monitor the renal function and complete blood counts and differential. So you have to monitor the renal function of your patient. You have to monitor the level of what? Blood urea nitrogen, the creatinine. So as nurses, you need to know the normal range of all these things. You have to know the normal range of creatinine, blood urea nitrogen. Take, for instance, the creatinine now. The normal range is 0.6 to 1.2. Then for blood urea nitrogen, the normal level is about, I think, 8 to 20. Some will say, okay, 10 to 20. So you have to monitor what these are the things that will make you to know whether the kidney is failing or not. So you have to monitor the renal function of this patient. Then you have to monitor the potassium level. Then avoid use with potassium-retaining diuretics or potassium-sparing diuretics. Example is what? Spironolactone. You all know that this potassium-retaining diuretics, they spare potassium. Even when they are getting rid of all other electrolytes, they still spare what? Potassium. So potassium is not lost. So you don't want to give your patients with on angiotensin-converting enzymes inhibitor. You don't want to give them what? Spironolactone. So please take note, very, very important. So you cannot combine these two medications. You can't combine spironolactone or any form of what? Potassium-sparing diuretics with what? With angiotensin-converting enzyme inhibitor. Because ACE will make the potassium to go up. And definitely, potassium-sparing diuretic is also sparing potassium. So there will be an high level of potassium in the blood, which is very dangerous for the heart. It is very dangerous, very risky for the patient's heart. Then you have to monitor for what? Angioedema. Now, take a look at this particular slide. You can see this diagram. This is an example. So it can really be very, very terrible when a patient has angioedema. So this is a picture for you to know how terrible it can be. It can lead to total airway obstruction. So you have to really monitor your patient for angioedema. Another example, you can see another slide showing angioedema. So you can see that this woman's tongue is swollen. It is really, really swollen. So how do you expect this woman to breathe? How do you expect that? You can see, if you are not careful, the airway of this particular patient can be totally what? Obstructed. And you will lose the patient before you know it. So please do not joke with this particular medication. Angiotensin-converting enzyme inhibitor. Do not joke with it. Seriously, you have to monitor your patient for all these major side effects that are spoken about. Now, we are going to ARB, which I discussed earlier. Angiotensin II receptor blockers. Angiotensin II receptor blockers. So what happens here is that it has like the same, it's almost similar to angiotensin-converting enzyme inhibitor. So it blocks the action, but not the production of angiotensin II. So it's an angiotensin II receptor blocker. You know that angiotensin-converting enzyme inhibitor prevents angiotensin I from being converted to angiotensin II. But angiotensin II receptor blockers doesn't do that. It only blocks the action of what? Of angiotensin II. It does not stop angiotensin I from being converted to angiotensin II. So it blocks the access of angiotensin II to its receptors. Angiotensin II being a vasoconstrictor, it has its receptors in the heart, in the blood vessels, and the adrenals. So it will not block the what? It blocks the access of angiotensin II. And once angiotensin II is blocked, being a vasoconstrictor, what will happen? There will be vasodilation and blood pressure will come down. So ARB prevents peripheral vasoconstriction and secretion of aldosterone. and it blocks the binding of A2 to type type 1A2 receptors. So this is just the mode of action of what? Angiotensin II receptor blockers. So both angiotensin converting enzyme inhibitors and ARB affect only the BP. So please take note. Both medications affect only the blood pressure. They do not have any effect on the heart rate. They do not have any effect on the heart rate. They have business with blood pressure and not the heart rate. So with angiotensin II receptor blockers, there is lower incidence of cough. So that is why it is easy for you to change your patient from what? From angiotensin converting enzyme inhibitors to angiotensin II receptor blockers when they are reacting, when they are having cough. You know, I told you earlier on that my mom was changed from angiotensin converting enzyme inhibitors to angiotensin II receptor blockers, the Satan. So in this type of drug, you will see the valsartan, the candesartan, we all know it. So that is why I didn't put it here. Most of them ends with what? Satan. Their suffix is what? Satan. So when the patient is reacting to angiotensin converting enzyme inhibitors, when they are having cough, you can change them to what? Angiotensin II receptor blockers, because there is lower incidence of cough with ARB. Then we are going to antiarrhythmic drugs, or you can call them antidystrythmics, whichever one. So what are antidystrythmic medications? What are they? They help suppress dysrhythmias by inhibiting abnormal pathways of electrical conduction through the heart. We all know that our heart has been designed in a way that if anything obstructs the normal electrical impulses, it will begin to malfunction. So what these antiarrhythmic drugs, what they do is that they help to what? They help to regulate, or they help to correct any form of disturbances in the electrical activity of the heart. So anything that obstructs or disturbs the normal electrical impulses, the way, their normal pathway, the way it functions, it will lead to what? It will lead to arrhythmia. Begin to what? It will begin to malfunction. The heart rhythm, it will begin to malfunction. It's either it become irregular, it can be too fast, and it can be too what? It can be too slow. So these antiarrhythmic drugs, what they do is that they help us to correct what? Those arrhythmias. They help us to correct those arrhythmia. They slow down the electrical activity in the heart by altering various ion channels within the heart. So we have different types of all these abnormal cardiac rhythm. We have sinus bradycardia, we have sinus tachycardia, we have a supraventricular tachycardia, we have the atrial fibrillation, we have the atrial flutter, we have the ventricular fibrillation. So if you really want to understand this medication or how it works, you need the knowledge of what? EKG. You need the knowledge of EKG, although it is not part of your what? It is not part of your curriculum. This EKG is not in your curriculum, but peradventure you want me to talk about it, or you want me to speak about EKG, or you want me to have EKG class with you, you can comment. You can leave a comment in the comment section. Maybe we'll look for a time and then discuss about what? EKG, because you actually need the knowledge of this EKG to know how these medications work. Because we cannot talk about this medication without referring to what? EKG. So we have different classes of antiarrhythmic drugs. We have different classes. We have class 1, which are sodium channel blockers. We have class 2, which are beta blockers. We have class 3, which are potassium channel blockers. Then we have class 4, which are calcium channel blockers. You know, I told you that they alter various ion channels within the heart. You know that this, most of these ions or electrolyte, they play a role in making sure that the heart functions properly. So these antiarrhythmic drugs, they alter various ion channels in the heart. Now, what are the indications? What do we use them for? We use them for fast arrhythmias like atrial fibrillation, atrial flutter, ventricular tachycardia, and supraventricular tachycardia, and a whole lot of them. Now, let's go to class 1 antidystrythmic drugs. We have the sodium channel blockers, and it has 3 subdivisions. So this class 1 is divided into what? 3 major subdivisions. We have the class 1A. So under class 1A, you will see disopyramide, you can see prokinamide, and quinidine sulfate. That is under class 1A. Then class 1B, we have the lidocaine, mesilethine hydrochloride, and phenytoin. This is also what? Under class 1B. Then under class 1C, we have flecainide acetate, propafenone hydrochloride. Then what are the side and adverse effects of these class 1 antiarrhythmic drugs? We have hypotension. It can cause heart failure, worsened or new dysrhythmia. It can cause nausea, vomiting, and it can cause diarrhea. So we use this particular one, we use it majorly for ventricular what? We use it for VTAC. We use it for VTAC and VVIP. That's ventricular fibrillation. We use it for ventricular tachycardia and ventricular fibrillation. Now let's go to class 2. We have the beta blockers. So these are used majorly for atrial flutter, atrial fibrillation, and hypertension. Then example of beta blockers, we are still going to talk about it. Example of beta blockers here is what? Acebutolol, esmolol, propranolol. Most of these beta blockers, they end in what? Lol, Lord. So that is how we can remember them. They end in what? Lol. So side and adverse effects can cause dizziness, fatigue, hypotension, bradycardia, heart failure, dysrhythmia, heart block, bronchospasm. So it can cause spasm of the what? Of the bronchioles. Then gastrointestinal distress. Now let's talk about class 3 antidysrhythmic medications. We have the potassium channel blockers. So it is also used for what? VTAC and ventricular fibrillation. Example of these drugs are what? Amiodarone, leufelide, butilide. What are the side effects? It can cause hypotension, bradycardia, nausea, vomiting. Amiodarone hydrochloride may cause pulmonary fibrosis. Yes. So this is a major side effect of amiodarone. Please take note. Pulmonary fibrosis. Then photosensitivity, bluish skin discoloration, corneal deposit, peripheral neuropathy, tremor, poor coordination, abnormal gait, and hypothyroidism. So for amiodarone, please take note. It can make a patient to have what? Pulmonary fibrosis. It can cause what? It can cause pulmonary fibrosis. It can also cause photosensitivity. So please take note, this amiodarone is a very dangerous medication. So when a patient is on it, you have to monitor that patient very, very well. Now, the electrocardiogram should be monitored for clients receiving amiodarone or dofetilide because they may prolong the QT interval, potentially leading to torsades de pointes. So this torsades de pointes is a ventricular tachycardia that occurs in the setting of long QT interval. So all these might sound strange to you, honestly, if you don't have the knowledge of EKG. So that is why I'm saying, okay, maybe you should look for a time and talk about what and discuss about EKG. Even if you don't have a deep-seated knowledge of EKG, you can just know the basics. Very, very important, because as nurses, you should be able to read what? EKG strip. When a doctor says, okay, when a doctor orders EKG for your patient, and the patient comes back or the result comes out, then you should be able to pick up an EKG strip and be able to detect on the EKG strip that, okay, is this patient having sinus tachycardia? Is this patient having sinus bradycardia? Is this patient having atrial flutter, atrial fibrillation? Because there is a way it will show on the EKG reading that will help you to know. So if you don't have a knowledge of EKG, all these will be very, very, very difficult for you to understand. So class 4 antidysrhythmic, we have the calcium channel blockers. These are the medications that we know too. Calcium channel blockers, the verapamil, the diltiazem. And another one, the most common ones are the nifedipine, which we all use. So it's an example of what? Calcium channel blocker. So you can use this for what? Atrial fibrillation, atrial flutter, and hypertension. So let's talk about the side effects. Can cause dizziness, hypotension, bradycardia, edema, constipation. Then let's talk about other antidysrhythmic drugs that we have. We have the adenosine, then the digoxin. You can use the adenosine for supraventricular tachycardia. In fact, that is the major drug that we use in patients with what? Supraventricular tachycardia. Then for digoxin, we use it to treat atrial fibrillation. Now, what are the interventions? What are your nursing intervention when the patients are on antidysrhythmic medications? You have to continue to monitor their heart rate, the respiratory rate, the blood pressure, because most of the time they cause what? Cause hypotension. You have to monitor the what? Electrocardiogram, that is the EKG. You don't just place patients on antidysrhythmic medication. You have to continue to monitor what? The EKG. Very, very important. Provide continuous cardiac monitoring. Maintain therapeutic serum medication level. All of these antidysrhythmic medications, they are high-risk medications. They are high-risk medication. So you don't want to joke with them. So when patients are on all these medications, we want to continue to monitor the therapeutic level. These medications are therapeutic level. Please go and read about it. All these medications that we use, they have their therapeutic level. It shouldn't be below the therapeutic level, and it shouldn't be above. So that's why you have to monitor their therapeutic level to make sure that, okay, they are still within the therapeutic range in the patient bloodstream, because they shouldn't be below their therapeutic range, and it should not be above. So you have to make sure that when you are administering these medications to patient, you continue to monitor the therapeutic range to make sure, because once this particular medication goes below the therapeutic range within the bloodstream, what will happen? It will not be effective. It will not do the work that you want it to do. And once it is above the therapeutic range, then it will be doing too much. That means we have excess of this medication in the bloodstream. So that is why it is important for you to monitor the therapeutic level of this medication. Then before administering lidocaine, always check the vial label to prevent administering a form that contains, we have lidocaine that has that contains epinephrine, that has epinephrine. We use it for what? Local anesthesia. So you have to read the label very well before administering it to a patient to make sure that it does not contain epinephrine or preservatives, because these are used for local anesthesia only. So today, if you don't know that lidocaine is an antidysphotic drug, then today you have known it. So lidocaine is not a local anesthetic agent alone. We use it as an antidysphotic medication. Do not administer this medication with food, because they may affect food may affect their absorption. Then mesleucin may be administered with food or antacid to reduce gastrointestinal distress. Normally, most medications, you don't want to administer it with antacid, because antacid decreases the absorption of it decreases the absorption of medication. It makes them to be less potent. So when you want to administer antacid with another medication, you make sure you administer it 30 minutes to 1 hour before that medication, or 30 minutes to 1 hour after that medication. But in the case of mesleucin, you can administer it with with antacid to reduce gastrointestinal disturbances. Then always administer IV antidysphotic via an infusion pump. Always administer IV antidysphotics via an infusion pump to make sure that it is delivering the appropriate dosage, appropriate drop per minute. Then monitor IV sites for infiltration. So amiodarone is a vesicant. They are vesicants. Vesicants are medications that can burn your patient's vein. So you don't want to joke with this medication when patients are on it, because they can burn the vein. They can cause phlebitis. So when you administer it to your patient, you want to monitor the IV site for infiltration, because it is a vesicant and it can burn the vein. Then I told you earlier on that one of the major side effects of amiodarone is pulmonary fibrosis. So you have to keep on monitoring the lungs. You ask your patient to go for chest X-ray. So you continue to ask your patient to go for chest X-ray, because of the side effects that comes with amiodarone, which is pulmonary fibrosis. Then monitor for signs of fluid retention, such as weight gain, peripheral edema, and shortness of breath. Advise the client to limit fluid and salt intake to minimize fluid retention. Monitor respiratory, thyroid, and neurological functions. Instruct the client to change position slowly to minimize orthostatic hypotension. Instruct the client taking amiodarone to use sunscreen. I told you earlier on that it can cause photosensitivity. So when these patients are going out, tell them to use sunscreen. Then you tell them to put on protective clothing. They should not expose their body, because this photosensitivity skin, patients with photosensitivity skin it can be serious. So instruct them to use protective clothing to prevent photosensitivity reaction. So when patients have photosensitivity reaction, it can really be very fatal. So you have to tell your patient to cover their body, to cover their skin when they are going out. Then you tell them to avoid staying outside between 10 a.m. and 4 p.m. This is usually the time when we have this sunshine. So this is the time that you can have the peak of sunshine. So you tell them to avoid any form of exposure to sun between 10 a.m. and 4 p.m. So when they're going out, tell them to put on a protective clothing. They can put on hats. They can put on sunshade. Then the kind of cream they will be using. That means it must have a sun protective factor, this SPF, and it must not be less than 50. Then encourage the client to increase fiber intake to prevent constipation. So peradventure you have any question about all these cardiac medications that we have described, that we have talked about today, then you can leave your comments. You can write in the comment section, ask your question if you are confused, or you have any addition, any contribution, just comment. Just write in the comment section your question, your contribution. And earlier on, I told you to read about RAS system. Very, very important. Read about the RAS system and drop your comments within the comment section, what you have read about the RAS system. Very, very important. So we have come to the end of the lecture, and I wish you all the best. Do not skip any part of this video. Watch from beginning to the end. So we'll see during the next class. Bye and have a lovely day. Thank you.